Thank you, chairpersons, and I'll be quick because this is my last. LADA. Everybody spoke about type 1. LADA, we are going to see a case-based discussion, but before we go to the cases, I'll just tell a brief introduction about LADA. LADA is the same as type 1. It's an autoimmune disease, but begins in adulthood. LADA, by definition itself, is a disease of adults. What does WHO define LADA as? It is a slowly evolving immune-related diabetes. Type 1, the presentation is very dramatic, but the poor LADA patients, they are misdiagnosed as type 2. They go doctor to doctor, and then finally we reach a diagnosis after many years of hyperglycemia. So what is the criteria for diagnosis of LADA? The Immunology for Diabetes Society says 3 criteria: age more than 30, positive autoantibodies to islet beta cells, insulin independence for at least the initial 6 months. But in practice, friends, even after 6 years after developing diabetes, they are not on insulin. They are mostly on multiple OADs and they roam around with very poor glycemic control. That is the real picture for our LADA patients. So LADA is also called a type 1.5 diabetes because it shares genetic, immunological and metabolic features with both the diabetes. So let's see how does it differ from type 1 and type 2. Type 1, of course, very dramatic presentation. C-peptide will be hardly there. The antibody titer is high and basal bolus insulin is the treatment. They will be having a family history of autoimmune disease. LADA comes somewhere in between. That is why most of the LADA patients get treated as type 2 diabetes, at least in the first 7 to 8 years of their diagnosis. So LADA here, I've given 30 to 50 years, but there is no upper limit of diagnosing LADA. Last year, I diagnosed a 75-year-old gentleman with LADA, and he's doing very well with basal bolus insulin. So don't think LADA is only for 30 to 50. You must keep your eyes and ears open to pick up LADA in any age group more than 30 years. So it is a heterogeneous disease characterized by less intensive autoimmune process. The autoimmune process is dramatic in type 1. Here it is slowly evolving beta cell loss, and that's why the insulin therapy unfortunately is started very, very late in this patient. So here the C-peptide levels decrease very, very slowly, and this marker is used to stage the LADA patients, and according to the residual beta cell functions, we give the insulin. So let me tell you, this is a consensus statement from an international expert panel. C-peptide, when you check for your patient, LADA patient, suspected LADA patient, less than 0.3, basal bolus, just like type 1. C-peptide more than 0.3 but less than 0.7, they say give insulin plus you can use drugs. But in practice, friends, even when the patient comes with 0.3 to 0.7, they respond very dramatically to basal bolus insulin therapy. C-peptide above 0.7 is what the expert consensus say you treat it as type 2. But here also, in my practice, a BD dose of glargine will make a lot of difference in the quality of life of these patients. So this is the consensus statement. If you see, C-peptide very low, basal bolus 0.3 to 0.7, you can use basal insulin plus some drugs. And more than 0.7, they are saying type 2, but in practice, I use a lot of insulin in my patients with even 0.7 to 0.9. And patients are very willing because once you start the basal insulin, the sugar starts coming down and they start, feeling much better. They will have all the signs and symptoms of type 1. They will have polyuria, they will have excessive thirst. I had a patient from Rajasthan. He had come and he had a big bottle of ice water in his hand, and every half an hour he had to use the washroom. That was his symptoms. That much severe were his symptoms of LADA. So, importance of insulin, friends. LADA is a gradual insulin-dependent progression characteristics. So, insulin is deemed necessary, according to me, even during the clinical non-insulin independent state also they will need. If you're clever enough, you just suspect LADA in a young patient and do the C-peptide, and if it's just 0.7 or 0.9, just give them metformin and 2 times glargine, he recovers dramatically. So research indicates that insulin therapy effectively preserves the residual beta cell functions and reduces the severity of insulitis. I have many LADA patients without bolus insulin, just 2 times glargine and some sensitizers. So this was the study I presented in Vellore Endocrinology International Congress this January, and this was done in my clinic. So it was a retrospective cohort study. 15 patients, they were all enrolled between 2020 to 2023. Let me tell you the characteristics of these patients. The age were more than age more than 30 years, high HbA1c. All of them had very, very high HbA1c. The one from Rajasthan had around 17% HbA1c. History of weight loss. Average duration of diabetes, they were all not newly diagnosed. They already had diabetes for 10 to 12 years. Been to various doctors. Most of the time I was the 7th or 8th doctor. So the current treatment regimen, you'll be surprised, most of them were on 3 OADs, which included sulfonylurea, and they were on premix insulin. Believe me, they were on premix insulin, and mostly they had high doses of premix insulin. You may be wondering, then why did the patient, they don't respond to premix. Just like your type 1, there was a lot of advocacy yesterday about basal bolus for type 1s. There should be basal bolus for LADAs also, because they respond very dramatically. So here I did the fasting C-peptide level, GAD65 antibody. I got a grant from Lupin Metabolics. So we did GAD65 for all these patients. All 15 patients had very, very low C-peptide levels. 14 out of 15 tested positive for GAD65 antibody, and 10 out of 15 had other autoimmune diseases like hypothyroidism. 1% had Graves. So here what was the treatment given? All OADs were stopped. Premix insulin was stopped. Basal bolus insulin therapy was started. And it was easy to convince these patients because already 10 years they've been living with high diabetes. They've gone to doctor onto doctor. So when I tell, चार बार अब insulin लगाओ, your sugar will come down, they are very happy, and it's easy to convince them. And regular self-monitoring of blood glucose was done for these patients. Some of them were put on CMs. I taught them carbohydrate counting just like the type 1 children, because the family members, when they think इसको बहुत ज़्यादा है, they were giving them only karela का sabji and some chapati, one chapati, just like a type 2. So here when you teach carbohydrate counting, their life becomes easier. So they were taught to count the carbohydrates, and believe me, even elderly patients, 65 plus patients, learn very enthusiastically the carbohydrate. Don't think it's only the children. Even they have that, zest for living. They learn the carbohydrate counting and they take their basal bolus accordingly. So clinical improvements in all these 15 patients, dramatic improvement, HbA1c reduction, weight gain, improved quality of life. Of course, after 6 or 7 months, they become, the doses, the boluses will increase. So I had to put them on metformin. And some of them, for the post-meal peaks, they are on acarbose after 6 months. After 6 months, they become healthy. So this is the demographics of my study. If you see, the HbA1c was 14.8 plus or minus 1.2 when they presented. With basal bolus, it came down to 8.8. Less than 0.3, 6 of them had less than 0.3 C-peptide. 6 of them had 0.3 to 0.7, and 3 of them had 0.7. And 14 out of 15 were GAD antibody. So, when should you clinically suspect LADA? Age above 30 years, getting treated as type 2 diabetes, poor glycemic control in spite of 3 OADs, which will include a SU and premix insulin. And all these 15 patients in my study were on very high doses of premix insulin, but they had very high HbA1c levels. So do a C-peptide fasting when you suspect LADA and GAD65 antibody testing. Treatment, when they come to you with a C-peptide of less than 0.3, please stop all OADs, stop the premix, put them on basal bolus. And as I told you, they would have suffered for many years. So they easily, accepted, okay, 4 bar insulin lena hai, I will do it. And limitations, of course, it was only 15 patients. This was from 2023 till 20 to 23. So after that, I have lot of data which I have to publish. So clinical trials and cohort studies are still required to get this point across that even LADA patients need basal bolus. Summary, friends, LADA, it is an autoimmune disease since in adulthood, requires insulin, not in the first 6 months, they say, but many years they are roam around without insulin. Early recognition is paramount because we have strategies to the beta cell destruction. Clinicians should consider screening for LADA in patients with type 2 who do not respond to 3 OADs and premixation. Fasting, post-meal C-peptide and GAD65 antibody have to do. Personal experience, this open to the forum. No upper age limit beyond which you cannot say 50 हो गया 50 के बाद लाड़ा नहीं हो सकता है. You can. I told you, 75-year-old I recently diagnosed. He's on basal bolus, doing excellently well. Learned carbohydrate counting. He's so sincere. And I find, this is a question for the panelists. I find glargine twice a day in all my type 1 patients as well as LADA patients. Basal insulin, I find glargine twice a day better than the long-acting analogs. I feel the fine-tuning can be done properly, and somehow I feel glargine BD is better than the long-acting analog. Of course, I'll leave it to the panelists. Thank you.
So much, ma'am.